So, I mean, even everybody is very focused on the use and the optimization of treatment with CAR-T. The reality is that if you look at the progression-free survival curves, they are not higher than 40%. And this applies to the third line or plus relapse setting and also in the second line setting. So if we look at the data coming from SUMA-7 and Transform, progression-free survival is around 40%. So even in the best of the cases, although maybe we would like to have specific analysis looking at the specific subgroups, because maybe not all the subgroups are going to behave equally, we have a significant proportion of patients that relapse after CAR-T. Unfortunately, it's quite a new landscape, the one that we are facing. So we know how to use CAR-T cells. We know prognostic factors that will segregate patients that are going to do better or worse with CAR-T, but we still don't have a standard of care for those patients that relapse after CAR-T. If we look at the characteristics of relapses after CAR-T, we can eventually think about different mechanisms. We can have relapses that are CD19 negative and relapses that are CD19 positives, and basically taking into consideration all these aspects that I think that we still need to work more on them and to better understand. Maybe we can optimize, before the patient relapses, some different strategies to try to decrease the relapse rate after CAR-T. But when the patient relapses, what to do with them? This is quite unclear. And we have different options that I think that most of them had been eventually tested, and some of them have already been published. But unfortunately, we cannot say nowadays which one is the best one or if this one is better than the other one. And probably we are not going to be using in the future the same options for all the patients. So probably with a better understanding of the biology of the relapse, of the biology of the disease and the type of relapse, and of course the type of patients that we have in front of us, we will be selecting one strategy or the other one. So radiotherapy can be a good treatment strategy for patients that relapse after CAR-T. Of course, this would be probably a most effective strategy if we are facing a patient that has localized relapse disease, not a patient that has widespread disease. Probably radiotherapy is not going to be the best option here. Of course, we can always think about giving the patient additional salvage chemotherapy, depending on what the patient has received. And there are some data indicating that consolidation with an allogeneic stem cell transplantation might be an option. But of course, our transplant has its own toxicity per se. And if the patient has relapsed quite early after CAR-T, we may think that we are basically increasing a lot the toxicity profile that we are giving to the patient. And then, of course, we have many potential treatment strategies which are not related to chemotherapy. There are some data regarding the possibility to use lenalidomide, which quite good results. And I think that there is an open field for new treatment strategies. At least from my point of view, one of the treatment strategies that maybe is going to be more successful in the future is the possibility to use bispecific monoclonal antibodies. So we don't have bispecific monoclonal antibodies accessible into the market, but we have quite a lot of information coming from prospective clinical trials. The long-term follow-up of bispecifics, of course, is not the same one that the one that we have for patients being treated with CAR-T, but we are seeing durable responses with bispecifics, decent progression-free survival curves, and basically, for instance, with Epcoritamab and Glofitamab, there are specific subgroups of patients that were included because of failure to a CAR-T. So again, not a huge number of patients, not a very long follow-up, but the overall response rate and the complete remission rate of patients that received either Epcoritamab or Glofitamab because of a failure after a CAR-T cell therapy, the overall response rate was really quite interesting and quite similar to the overall response rate and complete remission rate of the global population of patients. So I think that new drugs, maybe bispecific, is one of the ones that we have more compelling and maybe more solid data, would be a treatment strategy for those patients that fail CAR T in the future.